I'm going to talk just a little about the pathophysiology of anemia in chronic kidney disease. It's really multifactorial, and I think we've always known that, but there's possibly even a little bit more understanding of that right now, that blood loss directly occurs in chronic kidney disease, and then inflammation can occur, which can increase hepcidin levels, as we were talking about before, which then in turn can lead to iron deficiency. And then uremic toxins can shorten red blood cell lifespan. And then, of course, we all have known for a long time that with kidney failure, there's decreased production of erythropoietin. And so all of these things combine together to really cause and exacerbate anemia as chronic kidney disease continues to progress. So in terms of how we take that pathophysiology and translate it into treatment, we have really three main pillars of treatment right now. The first is iron administration to address that iron deficiency. And we'll talk a little bit more about that later, about how we do that and what the limitations are there. Second, we can administer now erythropoietin stimulating agents to address the decreased EPO production. And then third, less desirable but still effective, is transfusion to replace red blood cells. So now let's look at some new emerging therapies for anemia.
Thanks, Kirsten. And yes, let's look at some of these new emerging therapies. In order to think about these therapies, I think it's important to look at the mechanism of action of hypoxia-inducible factors, PHIs, for the treatment of anemia CKD. Again, to summarize, there are two essential components of how these agents work. First, the stabilization of HIF2 results in the synthesis of erythropoietin by the liver and the kidneys. Data has already demonstrated, even among patients who have failing kidney function and increased kidney fibrosis, endogenous erythropoietin doesn't come from the kidney alone, but comes from the liver as well. And as time goes by and kidneys basically get completely fibrosed and completely fail to produce erythropoietin, almost all of the erythropoietin production comes from the liver. And this has been shown even among patients who are anephric. This then results in endogenous erythropoietin, which then stimulates the bone marrow to produce red cells. The other part of the action of oral HIF is action occurring in the duodenum. HIF2 is stabilized by these oral PHIs, and in essence acts on duodenal cytochrome B, or DCYTB, to catalyze the conversion of ferric into ferrous, which then acts on divalent metal transporter 1, DMT1, to essentially facilitate the absorption of ferrous through the duodenal channel, ferroportin, into the body. There are two important players there. One is obviously ceruloplasmin, which is a HIF-regulated copper-carrying ferroxidase that catalyzes this oxidation of ferrous back to ferric, which then is transported around the body by the reticular endothelial system to various storage sites, including the liver, muscle, etc. So in essence, you have two actions of oral HIF-PHI. The first one, I think, has been amply demonstrated in clinical trials, both phase 2 and phase 3, and we'll discuss that in a minute. The other action, the action on absorption of iron that happens directly, is something that hasn't been quite teased out in clinical trials, but I think in the next several years will be the subject of quite significant insights.